Hello, I'm Rick Godley. I'm an otolaryngologist, but I'm also the president of the Association of Migraine Disorders. I want to thank Allison Feldman and the Facial Pain Association for the opportunity to discuss what is sinus migraine and why should we care about it. I can tell you why I care. For the past 10 years, I have at first been perplexed and am now fascinated by a patient story that I've heard over and over again, with several variations. That story usually begins with a middle-aged woman, and she describes having pain or just pressure in her face. It's usually centered around or behind her eyes, but it can be across her forehead, deep to her nose, or within her cheeks. She might add that she can't breathe normally through her nose and is constantly blowing it. She tells me about the failed treatments that she's tried over the past several years. She has been using nasal saline spray or irrigation every day, steroid nasal sprays that taste badly, antihistamines that dry her mouth, and has taken 2, 4, or 6 courses of antibiotics, and oral steroids, which either scare her or make her feel worse. She may have even had sinus surgery. She feels horrible 3 or 4 days a week. She also feels dizzy and can't think straight. She's worried that she might lose her job. Sometimes she has choice words about the experience with her doctors. But in general, she's frustrated, worried that there's no relief in sight, and discouraged. Yes, she's losing hope. At the end of her story, she asks, "Doc, why don't I get better?" What I want to focus on is the possibility that the patient is being confused by her symptoms. I believe the answer to her question is to challenge the way that we've been thinking about this problem. When I say we, I mean the patient and the medical establishment. We've had blinders on. We have oversimplified this problem, and it's time to rethink the issue. If I tell you what I tell my patients, I think you'll get the point. I usually begin by explaining what it means to say, "I've got a sinus infection." It can take some time and effort, but I want the patient to agree with me when I try to change the conclusion that she has come to. First, it helps if she knows the basics about her own anatomy. To understand her symptoms, it helps to know the difference between the nose and the sinuses. The nose is an airway. It's a way for air to get to the lungs. There are 2 passageways through the nose divided by a wall, the septum. From the side walls hang 3 pair of turbinates. These are bony fins covered by a thin layer of soft tissue called mucosa. The mucosa of the lowest or inferior turbinate is filled with blood vessels. It is the blood coursing through those inferior turbinates that make them function like radiators, because the blood in the turbinates moistens and warms the air we breathe. And it's this capability that makes nasal breathing superior to mouth breathing. The mucosa also contains glands that produce mucus. That mucus can be thick or thin, clear, cloudy, or colored. Mucosa also contains microscopic cilia or hairs. They synchronize their beating motion to move mucus either to the front or the back of the nose. Therefore, when you talk to your caregiver about your symptoms, provide specific details. In contrast, sinuses are air pockets that form within the dense bone of the face. Normally, they're empty, other than the fact that they are lined by mucosa. There are generally 4 pairs of paranasal sinuses. They grew out of the nasal airway, so each one has a narrow opening or ostia connecting to the nose. It's when the mucosa swells from allergies or a cold that one or more of the narrow ostia can become blocked. The air that is trapped within the blocked sinus begins to be absorbed, and a vacuum or negative pressure develops within the sinus. Secretions have nowhere to go, and now conditions are perfect for the few bacteria that are always in the sinuses to flourish. Now, you have pressure, pain, and pus, and this is what we traditionally think of as a sinus infection. Let's get back to our patient's story. Now, the patient has come in and told us she has pain and pressure with a stuffy, runny nose. Given these symptoms, particularly if she's insistent that she has a sinus infection, most clinicians are going to agree. You might ask, Won't the medical professional know that I have a sinus infection when he or she does a physical exam? Okay, the doctor may press on her cheeks, ouch, or look in her nose and convince himself that the big red turbinates are caused by infection. But really, it's unusual for the examination to reveal any clear evidence to contradict the assumption that this is a sinus infection. After all, the doctor has to believe that he or she knows what's going on. The reality is the clinician can't see what's happening inside the sinuses. Whoa, I thought the camera that was pushed deep in my nose gave us the answer. Not so fast. In most cases, we clinicians, even with our endoscope, still can't see inside the sinuses. And in my experience, there's rarely any suspicious secretions to be seen inside the nose. You might say, how about those fancy imaging machines? Surely they can show us what's going on inside the sinuses. And indeed, of all the available imaging modalities, the CT scanner is best at showing what's inside the sinuses, and in great detail. That being said, let me explain why this test is not the answer. The weakness of CT scans is how they are interpreted. This is how that usually goes. If we look at the image on the left, the sinuses are all uniformly black. Black is beautiful because it means the sinuses are filled with air and not much else. This is interpreted as a normal CT scan. In the right image, there are clumps of gray material almost filling the sinuses. This is interpreted as an abnormal CT scan. But what does it mean to be abnormal? In other words, what is that gray material telling us about what's going on inside the sinuses? The gray material may be either swollen mucosa or pooled secretions, and that makes a difference. Because swollen mucosa can be created by conditions other than an infection. In the left image, we're probably looking at nasal polyp disease. If anyone in the audience has this chronic condition, they can tell you that it blocks their nose and affects their sense of smell, but usually doesn't cause any pain. Nasal polyp disease is probably an odd malfunction of the immune system that causes the mucosa to become edematous or swollen. What it rarely is a horrible infection. On the right image, we see a large clump of gray material in one of the maxillary sinuses. All of the other sinuses look normal. This is a retention cyst, and they're very common. They are caused by a blocked gland. Retention cysts also don't cause pain and rarely need treatment. The other finding on abnormal CT scans is the gray material representing fluid that has gotten trapped in one or more sinuses. This fluid can be harmless salt water from a nasal irrigation or evidence of an active infection producing pus. The challenge with these images is to figure out if we're looking at fluid or just swollen mucosa. There are two clues on CT scan that help us identify fluid. One is to see a meniscus, or pooling of gray material in the dependent part of a sinus. The second is the presence of small air bubbles, or froth. If we look at these images, I've circled in yellow a sinus containing gray material, artificially colored green in this picture, that has a smooth, convex surface, and, from a second angle, the mucosa can be seen swollen uniformly around the rim of the sinus without any pooled secretions. This is probably just swollen mucosa. On the other hand, circled in red, a second sinus contains a more flat surface with tiny irregularities on the surface. I think that this is a meniscus with a frothy surface. As best as I can tell, this represents fluid and likely an infection. I've gone into this topic in some detail to make the point that CT scans are hard to interpret. A radiologist will describe these findings, but the clinician who reads the report will often simplify the findings to mean the CT scan is abnormal and conclude that this is further evidence that the patient has a sinus infection. What the clinician may not know is that studies have shown over and over again that an abnormal CT scan is not the equivalent of a sinus infection. In fact, There's a grading system that's based on how much soft tissue is found on CT scan. The more soft tissue, the worse the rating, and by extension, the worse the sinus infection. By now, even you know that this grading system is just confusing the diagnosis. What is even more difficult for most clinicians to explain is why the majority of people with sinus complaints have a normal sinus CT. I think you get the idea now that there's no reliable diagnostic test for sinus infection. And this is how we get to the point where we need another explanation to the question, why don't I get better? It isn't enough to jump to the conclusion over and over again that the patient just has a recurring infection and needs more intense antibiotic therapy, or a chronic condition that doesn't respond to antibiotics and needs sinus surgery. This is the point where I suggest we take a step back and ask ourselves, what makes us feel pain and pressure in our sinuses? The answer is our sensory nervous system. And the next question is it possible that the problem is with the sensory nervous system? And let me be clear that I'm not suggesting that these symptoms are not real. It's simply that what is causing those symptoms is not what we tend to think it is. To explain how the sensory nervous system works, let's go back to the mucosa that is lining the sinuses. That mucosa contains sensors. They let us know when we're experiencing pain or pressure. And those sensors are connected to the brain by trigeminal nerves. And here's where the topic of sinus anatomy and migraine intersect. It's important to know that migraine is quintessentially a malfunction of the trigeminal nerve. The hallmark of migraine disease is a headache, and this is associated with the first branch of the trigeminal nerve. But there are at least two other branches of this sensory nerve, and they service the structures of our face. And in fact, migraine affects other parts of the nervous system beyond the trigeminal nerve. Think about an ocular migraine. I would assume that at least a few members of the audience have experienced an ocular migraine. If so, they know how strange and even scary they can be. For the rest of you, let me explain that an ocular migraine is where, out of nowhere, one begins to see flashes of light or strangely shaped images. You can lose some or all of your vision, usually in just one eye. It doesn't last long, and it does not need to be associated with any pain. There's nothing to be found on the eye exam or MRI of the brain. What is experienced is a momentary failure of vision. And what we think of as a problem with our eyes is really an issue with our whole visual nervous system. My point is, why this migraine phenomenon of the visual system can't be happening to the trigeminal nerve, specifically the pain and pressure sensors within the sinuses. To answer my own question, I certainly think it does. When I tell my patients they probably have a different form of migraine, I often get some pushback. If they're honest enough to tell me what they're thinking of my explanation, they'll say, I know what it is to get a migraine, and this is not a migraine. At this point, I like to explain more about migraine. One of the big differences with sinus pain and pressure when compared to a migraine headache, beyond the facts that pressure is a different sensation, the location is not what they're used to, they may not have had a migraine headache in years, is the fact that the symptoms linger for days or weeks. For those not familiar with migraine disease, let me review the two theoretic mechanisms that explain what generates migraine symptoms. The first is a corticospreading depression, and this lasts just hours or days. The second is central sensitization, and this causes symptoms to last much longer, days or months. A corticospreading depression is an electric storm that moves slowly across the brain. It's similar to an episode of epilepsy. Next, the electrical storm triggers the trigeminal nervous system. What you may never have known before is that the fibers of the trigeminal nerve travel with the blood vessels across and through the brain. When stimulated, the trigeminal nerves cause two effects. The first is to dilate the cerebral blood vessels, and that causes some pain. The second is the release of cytokines throughout the brain. These cytokines are a handful of proteins with crazy names like interleukin and interferon that control the immune system, for better, for worse. In this case, it's for worse. Cytokines cause inflammation inside the brain. It may be this neuroinflammation that is responsible for the pain during migraine attack, but it has a secondary effect that is important to appreciate. Inflammation within the brain may not be good for its circuitry. The consequence is that after many migraine attacks, the ensuing neuroinflammation causes changes to the brain, leading to spontaneous misfiring of sensory networks without a specific attack. This is called central sensitization. I propose that central sensitization is a likely explanation for why these nerves of the sinuses can produce sensations on and off that feel like a sinus infection. For most people to accept this hypothesis, I believe it will need its own name and specific diagnostic criteria. We're not there yet. Until that day comes, I choose to call this condition a sinus migraine. There are a few other things you should know about migraine disease. First, migraine is inherited. That means that it comes in a nice DNA package from one or both parents. This is one of the reasons to think about migraine as a disease. Unfortunately, migraine inheritance is not simple. Migraine is a messy reshuffling of a deck of minor genetic flaws. So far, we know of more than 30 different genes associated with migraine. They're called susceptibility genes. Some people carry a few of these genes and may have little or no symptoms. Others have a combination that causes them to be horribly sick. What may be surprising is that migraine susceptibility genes code for defective functions in nerves, but also in the vascular and immune systems. Migraine is a disease with a large spectrum of illnesses, probably because of the large number of combinations of these susceptibility genes and the many parts of the body that it can affect. In other words, migraine susceptibility genes begin to explain why so many people have different symptoms and different responses to treatment. What holds together this grab bag of genetic flaws is the common feature of a hypersensitive or hyperactive nervous system. Secondly, migraine symptoms tend to change during life. The fact that migraine symptoms peak during the reproductive years of women and triple the number of women who are experiencing migraine symptoms, even though they have the equal number of susceptibility genes as men, highlights the effect of sex hormones on this disease. Although we don't understand very well how sex hormones like estradiol affect nerves, women do see fluctuations in migraine symptoms during their menstrual cycle, pregnancy, or menopause. This is how it works. The body has a set of autonomic or automatic nerves. They work without us thinking about them. It's what makes our eyes dilate in the dark and our stomach grumble when we're hungry. The autonomic system has two different parts, the sympathetic and parasympathetic. It's the parasympathetic system that controls the blood flow and secretory glands within the nose and sinuses. In the same way, patients and clinicians often jump to the conclusion that when the nose runs, it must be an infection. But we now know that increased parasympathetic activity related to migraine can stimulate glands to produce mucus. It's gross, but it's really valuable to appreciate the difference between pus and a thick mucus. One represents the remnants of an infection. The other is due to overstimulation of normal glands. Now, I've explained how migraine might mimic a sinus infection, But I've also noted that patients cannot really tell what's causing the symptoms, and that the physical exam or CT scan is not very helpful. How are we going to diagnose this sinus migraine? The answer is to look for other evidence of migraine beyond sinus symptoms. These can be odd symptoms that you might not have associated with migraine, such as having unexpected brain fog, having the feeling that water is in the ear when no one can see it, feeling as if the ear is blocked but a tympanogram is normal, feeling off balance, or smelling odors that others don't. They are all indications that your nervous system is not working quite right, and they're all symptoms associated with migraine. And it's worth thinking back to your childhood. Did you have a period with one or more symptoms that went without explanation, such as colic, car sickness, stomach aches, or dizziness? It helps to recall if any relatives used to disappear into bedrooms or shut off the lights, or had headaches that were not even diagnosed as migraine. Maybe Uncle Pete or your mom. And finally, you need to know that migraine is often closely associated with other chronic diseases. 90% of those with chronic migraine have at least 3 other chronic conditions, and they're called comorbidities. Probably the fundamental reason that migraine has so many comorbidities relates back to all those susceptibility genes that overlap with other health conditions. People with migraine also have irritable bowel, hypothyroidism, or Raynaud's disease. Those with recurring sinusitis might ask themselves, do I have any of these coexisting chronic diseases, such as fibromyalgia, insomnia, or endometriosis? If so, the likelihood of having migraine is increased significantly. Figuring out if a condition is migraine variant or a comorbidity can be a challenge. Take trigeminal neuralgia as an example. You can classify this as a migraine comorbidity because while migraine might be one of the causes, there are several other well-established biologic processes that cause this condition. On the other hand, trigeminal neuralgia is defined by the intense pain of the trigeminal nerve. Maybe trigeminal neuralgia and migraine are simply on the same spectrum of a single disease. At this point, all we can say, based on existing evidence, is that those with migraine and aura have an increased risk of developing trigeminal neuralgia. Perhaps one day soon we'll know the answer to this dilemma. The bottom line is that the diagnosis of sinus migraine is primarily based on what you can remember about other migraine symptoms, present and past, comorbidities, and family history. Be your own best detective. And if you think migraine should be considered in your diagnosis of sinusitis, be an advocate for yourself. Okay, at this point, you may be rolling your eyes and wondering if I've fallen down a rabbit hole or got myself stuck on a deserted island. Let me assure you that I'm neither the first nor the only one who's been trying either to raise awareness of or to prove this hypothesis of a neurologic cause for rhinosinus symptoms. Let me point to 2 recent clinical studies that validate the high prevalence of facial pain and pressure among those with migraine. There are also studies to show that this is true of the symptoms of nasal congestion and runny nose. But frankly, what we really want to know about sinus migraine is, can you treat it? A useful way to determine the answer is with a clinical outcome study, such as the one I'm going to review from 2013. In this study, a group of 130 patients who had been previously diagnosed with sinusitis were treated in 3 different ways. The first approach was to use antibiotics and the other traditional methods of treating sinus infection. Patients reported that the medical approach only worked in about 20% of the group. Before I go on, this is a good time to tell you about an interesting but little known fact about antibiotics. It helps to explain why patients tell me they do feel better when they're taking the antibiotics, but the pain comes right back. The explanation may be that antibiotics not only kill bacteria, but many of them have an anti-inflammatory effect. Yes, they suppress those pesky cytokines. Less inflammation, less pain, but for less time. Getting back to the comparison of treatments, the same 2013 study showed that of the 12% who were treated with sinus surgery, only 23% reported that it was successful. Let me explain a confounding aspect of sinus surgery, or any nasal surgery. Nasal and sinus surgery inevitably remove and scars mucosa. As we've seen, there are nerves integrated into the mucosa. Removing or damaging mucosa will temporarily interrupt the function of the sensory nerves. Even if the cause of sinus pain and pressure is neurogenic, sinus surgery will make patients feel better. But is this a long-lasting result? Nerve fibers grow back very slowly. It may take 6 to 12 months to reestablish their function. Therefore, if patients are not asked about the success of their surgery at a year after the procedure, it may not be a valid measure of either its success or if it was even treating the right cause for the symptoms. Allow me another digression. Balloon sinuplasty is now a new rage. It seems so much safer and easier to use a catheter and balloon to open up sinus ostia, and it can be done in an office setting. But you need to know that the indication or the medically accepted reason for performing balloon sinuplasty has been broadened to include people complaining of sinus pressure but having normal sinus CT scans. The rationale is that the narrow ostia that do not allow the free exchange of air in the sinuses is the root cause of the feeling of sinus pressure. The weakness of this rationale was revealed in a prospective, single-blind, randomized controlled trial. It showed that patients with sinus pressure and a normal CT scan had outcomes from balloon sinuplasty that were no better than those of a sham operation. Returning to the 2013 comparative outcomes study, when the same patients with sinus complaints were treated with migraine therapies, they obtained symptomatic relief in almost 70% of patients. Now we're talking. This and several other studies have shown that if you treat patients with suspected sinus migraine with migraine medications, they usually get better. In my experience, this is the most convincing proof for patients, and so satisfying when we're finally able to make patients feel better again. So hopefully you're convinced there are some people out there who could benefit from a new diagnosis and treatment. But how many more people are there to treat differently? Based on several clinical studies, the evidence that bad nerves rather than bad bacteria are the cause of these midfacial symptoms is in 80% of patients with suspected rhinosinusitis. Then, how many people are we talking about? We know that about 10% of our population has at least one sinus infection per year. That's about 35 million Americans. If 80% of those have sinus migraine, we're talking about 28 million people a year who are at risk of being misdiagnosed and mistreated. So we need to care about this new diagnosis. Let's look at more evidence of the size and significance of this diagnostic blind spot. One recent study showed that sinus headache was the most common misdiagnosis among those with an inaccurate migraine diagnosis. Another way to judge how bad the current system is failing is how long do patients have to wait from their first doctor's appointment until they get the correct diagnosis. The average delay in diagnosis is almost 8 years. And there are consequences for the patients. First, patients pay a physical price for misdiagnosis. And we're not talking about a lot of people with sniffles. When people have sinus migraine, not only are they bothered by pain and pressure, but they're tired and lose concentration. In fact, a recent study pinpointed sinus headaches as the most severe form of migraine disability. This is in a disease that ranks third of all global diseases that affect a person's ability to function normally, and the highest of all disabilities in women 25 to 50 years of age, their most productive years. And not getting the correct diagnosis also means unnecessary exposure to common antibiotic side effects, changes in the intestinal biome leading to diarrhea, even serious consequences like C. difficile infections or an allergic reaction to an antibiotic. People are impacted by unnecessary hassles and costs of allergy treatments, as well as unneeded surgical procedures with their associated risks, pain, costs, and lost work. Misunderstanding the cause of rhinosinusitis has an effect on us all. When clinicians misuse antibiotics in treating facial pain, this ranks as the single highest contributor to inappropriate antibiotic stewardship. In other words, the inappropriate use of antibiotics leads to bacteria learning to survive our limited number of antibiotics. Also, when people are not treated properly for rhinosinusitis, it simply increases the number of days that they can't work. Currently, rhinosinusitis is a leading cause of poor worker productivity. It hurts businesses and our overall economy. And then there's the $12 billion squandering of our limited healthcare dollars. Now, I've outlined the problem, offered an explanation, and shown there's the opportunity to reduce suffering for the patient, safeguard our antibiotics, and all the while potentially save society some money. What do we do with all this information? Is the problem with the patient? No, because the patient is only reporting what she or he knows and feels. Is your doctor to blame? Well, not really. Doctors may not be suspicious enough or asking enough questions, but they are doing what they've been instructed to do. What I mean is, in medicine, we want to avoid clinicians from going rogue, so we produce clinical guidelines or treatment recommendations. They're often an algorithm. Currently, the clinical guidelines for rhinosinusitis ask clinicians to assume that if patients report facial pain or pressure, nasal congestion, and abnormal nasal discharge, and we know how unreliable that is, or clinicians observe signs and symptoms, meaning finding pus on nasal exam, and you'll have to trust me that this is rare, the patient has rhinosinusitis. The recommendations are to treat the patient with not just one, but 2 10-day courses of antibiotics before considering a CT scan, although we know that that may not give us the answer. Never do the guidelines recommend to ask questions about migraine. Without any alternative diagnosis, the cycle of antibiotics, plus or minus steroids, and other sinus remedies goes on until maybe surgery is performed. The bottom line is that clinical guidelines are antiquated and favor an infectious etiology. And how do headache specialists look at this issue? It seems they're not much better. Their diagnostic Bible, called the ICHD-3, has only one specific diagnostic category for rhinosinusitis, and that concept is limited to a description of rhinosinusitis as a trigger of a migraine headache. The bottom line is again focused doggedly on a person with a migraine headache, and that it might be triggered by a sinus infection. What these guidelines suggest is that if clinicians can just treat the abnormal CT scan properly, the headaches will go away. To fix this problem, I would propose developing a set of revised clinical guidelines. One that recommends every person complaining of facial pain or pressure be screened for migraine before a single antibiotic pill is prescribed. If the clinician feels the need to rule out an infection or other cause, recommend a cone CT scanner. It's a smaller CT scanner that can be in a doctor's office, offers the patient to comfortably sit in a chair, uses much less radiation, allows the clinician to review the images at the time of the visit, at the time when the patient is symptomatic, and the whole process is more efficient, more accurate, and costs less to boot. If the diagnosis is in doubt, recommend a trial of migraine medicine, which, by the way, would yield quicker and safer results than a 10-day trial of antibiotics. The problem is that clinical guidelines are based on medical literature, that is, peer-reviewed articles that support or discredit a hypothesis. Researchers need to provide the evidence that will shift this idea of sinus migraine from a supposition to a medical fact. Only when sinus migraine becomes a widely recognized entity will the next generation of clinicians be trained in its diagnosis and treatment. Therefore, the key to changing people's minds is high-quality research. Okay, that's a lofty goal, and to piece together enough convincing evidence to achieve this goal will take years. And so, when patients ask me what they can do now, I make 3 suggestions. First, I encourage them to learn about migraine disease, and then share that information with family, friends, coworkers, and bosses. They should have a better understanding of what you're going through. Although it might sound self-serving, I can proudly recommend starting with our AMD website, which offers many educational resources, including over 100 short podcasts, a newsletter, and much more, all in one place. But in all fairness, our organization works with many other great patient-empowering organizations. Together, these organizations and others provide an amazing variety of resources to help patients get over the hurdles to better health. Secondly, if a caregiver does not seem to know much about this subject, you can ask them if they've heard of a migraine toolbox. This is a free 6.5-hour online course in migraine management. It can be found on mycme.com. And thirdly, you can support research. And I'm not just talking about giving money. Increasing public awareness of migraine disease influences public opinion, and public opinion influences which diseases our government will give its research dollars to. We can all chip away at raising interest in migraine and other forms of facial pain every day. But for migraine, the big day is June 21st, Shades for Migraine. You may not have heard of this event yet, but you probably will soon. It's a day to wear a pair of sunglasses, preferably with a purple frame. Take a picture and share it on social media. Millions of people across the world have joined in on this simple and kooky event. People post pictures in iconic locations, wearing funny clothes, or donning sunglasses on their favorite pet. There's a program where you can combine the passing out of purple sunglasses with informational handouts. Just a thought. If you don't think that migraine and its related facial pain conditions don't need your help, let me remind you that those with migraine far outnumber those of all the major chronic neurologic diseases combined. And yet, NIH funding of migraine research and other forms of facial pain currently is much less than any of the other less common neurologic diseases. I suggest that both individuals and organizations that are committed to improving the lives of those with facial pain syndromes work together as much as possible. In closing, I've tried to answer the question of what is sinus migraine, and more importantly, the question of why we should care about it. But I've also suggested what needs to be done to change the way patients and clinicians think about rhinosinusitis. I hope you agree. In general, facial pain conditions are not widely appreciated for the invisible hardship that they inflict on millions of people's lives. But one day soon, I hope they will get the respect that they deserve. Thank you so much for your time.